Welcome to Grand Rounds, Special Topics, March 2025. With us today, we have Dr. Hamad Saleemi and Dr. Matthew Johnson talking to us about platelet-rich plasma injections. So, Dr. Saleemi is a primary care sports and spine medicine physician with dual board certification in physiatry, which is PM&R, and sports medicine. He provides treatment for all non-surgical musculoskeletal complaints, including ultrasound-guided procedures, injections, tenotomy, barbotage, etc., and biologic injections like platelet-rich plasma. Dr. Saleemi completed his medical school at New York College of Osteopathic Medicine in Long Island, New York. He completed an internship at Christiana Hospital in Delaware, followed by a 3-year residency in physical medicine and rehabilitation at Stony Brook University Hospital in New York. He then completed fellowship training in primary care sports medicine at United Health Services in Binghamton, New York, where he held an appointment as an assistant clinical professor at SUNY Upstate Medical University. Dr. Johnson graduated from Temple University with a bachelor's degree in kinesiology and then a doctor of physical therapy degree. He is board certified in both orthopedic and sports physical therapy, and he practices at St. Luke's Physical Therapy, where he is the facility director at the Sports Medicine and Rehabilitation Center. He is also faculty in the St. Luke's University Health Network Orthopedic Physical Therapy Residency. Dr. Johnson believes that the most effective treatments are evidence-based and personalized to the individual's needs. He specializes in the treatment of athletic patient population and assists in returning athletes to active individuals back to their previous level of competition. So, there we go. This is our credit information and our statement of need, and the target audience is to all healthcare providers. This is our designation statement, and the planners and presenters have nothing to disclose. And with that, these are our learning objectives, and I will turn this over to Dr. Saleemi.
Thank you. Let's see. Can you guys hear me okay?
We can.
Okay. You didn't want me to be on video, did you?
No, that's fine.
Okay. All right, so for this talk, we'll go over what platelet-rich plasma actually is. You hear about it, so we'll go over what it is and how it works. It's something already inside of you, so why is it something we withdraw and inject and somehow it helps? We'll go over some of the most common uses for it in MSK medicine, and then there'll be a couple of slides that will talk about what the patient experience is like. And then we'll go over some of the risks with it being something that's already inside of your body. You can only imagine that there's not a lot of risks, not too many risks involved with it. And then most important, what this talk is going to be, how can all of us collaborate together to get the best patient outcome from this. So what exactly is platelet-rich plasma? It's a treatment that finds a way to release a lot of growth factors at a site of injury or degeneration, somewhere where the body just doesn't heal as well as it can. So what I like to compare it to is, imagine when we were a lot younger, if you got a little superficial cut, like that picture on the left, how quickly things healed versus a lot later in life. That healing process can take a little bit longer. Or imagine some of your more senior patients, when they get a wound, how long it can take. So I kind of liken PRP to that, in that think about how things used to heal and think about how they heal now. This is just an adjunct to their treatment to enhance how their body heals. And that picture on the right side is just a blood cell, and then in the middle is that platelet. So I've gotten quite a few patients over the past few years. They ask about stem cells. Stem cells, PRP, are part of regenerative medicine. PRP is not stem cells, but it often gets mixed up. Stem cells, they're progenitor cells. They have the potential to become any type of cell and just keep multiplying. So with that, there's always this concern about malignancy coming from that. With that, it's also a lot more costly than platelet-rich plasma, at least 10 to 20 times more on average. And as of right now, there's not a lot of good data that it helps with a lot of these musculoskeletal issues. And if anybody follows the NFL or does fantasy football, Christian McCaffrey's a running back for the 49ers who went to Germany to get stem cells for his Achilles tendon. So if you had him on your team, you know how he did. He did not do well. So this is a little bit of biochemistry. So PRP, they're smaller cells. They come from megakaryocytes. So they're already divided. They don't have that same potential that stem cells do to become any cell. Just like stem cells, they are produced in your bone marrow and liver, and there's about 100 billion per day. They live for about a week, week and a half. They're very small, and they get activated at wound sites. So that becomes important. Some people, when they do these platelet-rich plasma injections, they'll, in some cases, you can add something that activates it, usually something like calcium chloride, thrombin, or collagen. And when they get to the wound site, they release these growth factors and cytokines, which can help other factors come in, which play a role in healing. So PRP is just your blood with higher concentration of platelets. That's really what it is. And to get that higher concentration of platelets, we use a centrifuge in office, and by spinning it, it separates out this part of your blood, this platelet-rich plasma, the supernatant, which we would draw off from the syringe, and then we inject it wherever you need it. In a little bit, I'll talk about some studies about platelet-rich plasma, but the biggest thing to take away right now is that there's different kinds of platelet-rich plasma, right? So when you draw the blood, how much blood are you drawing? How much platelet are you getting out of it? When you withdraw the blood, there's white blood cells in it. Is it leukocyte rich? Is it leukocyte poor? That can play a role. We talked about activation. And then there's different methods of centrifugation. There's a one spin in the machine. There's a double spin. Here at St. Luke's, we do one spin, which I'll get into a little bit. So this is a busy slide. It's going over how it works. So just like before, it's just getting a high amount of growth factors where you need it, a high concentration of cytokines, growth factors, and some of them are listed here. And that picture on the right goes over kind of how they're involved in the healing process. So you always have these factors throughout, but with platelet-rich plasma, we're concentrating all this where we need it. We'll go into some of the rehab protocol later. There comes a point after their injection treatment and as part of their physical therapy where we want to start loading it to promote new tissue, to degrade the old diseased tissue. So mechanical loading becomes important. In some cases, we do fenestration, which is just multiple passes through that tendon or ligament. That in itself can create a healing response because you're causing these microscopic tears. So use the tendons, ligament, muscles. You can also use it for muscle strains and contusion. And really how it works for that is there's usually a lot of blood formation or RBCs there. So just concentrating it more with platelets than would be in a muscle strain or contusion can help with that. And then Matt and I talked a little bit about how does platelet-rich plasma help with arthritis. A lot of studies looked at this, and one of the ways is that when we inject it into the osteoarthritic joint, it can stimulate these fibroblasts, which are responsible for leading to chondrocytes, which are part of your cartilage. They also can help stimulate your synovial cells that make lubricant or hyaluronic acid and hyaluronic acid, which sometimes we also inject into your knee. With PRP, initially there's a pro-inflammatory period, and then over time it lowers the inflammation. So that becomes important when we talk about some of the medicines we'll have the patient stop. So what is it used for? It's used for a lot of different things. I mean, from cosmetics to dental work. It's used in surgery too. I won't get into that much as I'm not a surgeon, but really it's used for so many different things. And this picture on the right, it's one of the first things that comes up if you Google platelet-rich plasma injections. And I kind of like it because it doesn't promise it as a cure-all. So kind of some of the stuff I mentioned there, and then you can see the cost. Average cost in America for PRP is about $1,000. And you can see there, it says repeats needed, no insurance. I'll get into that a little bit later. And then challenges, PRP quality varies dramatically. There's so much variability in it that a lot of these studies, because of that, it's a little tricky. And then I like that last thing it says there. Last two things, risk is low but not well defined, and then some clinics sell PRP as a panacea, which it's not. So these are some of the most common things we'll use it for. So you can see on the right there, that's an MRI of a patellar tendon with some tendinosis in it. Before we do PRP, especially if it's for a tendon or ligament, oftentimes I'll try to get an MRI before, just because that can kind of guide me as to where we want to put it. Because you can imagine, you can see in this picture, you see his patella. I don't know if you guys could see my mouse pointer. I have a laser pointer up.
Yes, we can see it.
Okay, good. So you could see here, if somebody came in with this significant patellar tendinosis, they're going to be pretty tender to palpation from the proximal pole down to at least mid pole, if not further distal. But with the MRI, you can kind of see where the main problem is. So with that, now we can use ultrasound here to find this area and try to get most of it in this area while also fenestrating and getting it into the other spots to help. And then I talked about it in use with osteoarthritis, ligamentous injuries like turf toe, cartilage issues, pubic symphysis. Personally, I haven't done it for that. Labral tears, really any muscle, tendon, ligament, joint issue. If I feel like it can help, I'm all for it. So what is the patient experience like? I try to have them stop all anti-inflammatories for at least a week before, because there's a pro-inflammatory period with the PRP that you want to remove the diseased tissue. And if you're taking anti-inflammatories, it can negate that effect. So I'll have them stop that. You can still do Tylenol because it's not an anti-inflammatory. And then really, they shouldn't have had any cortisone injections recently, because that's kind of the opposite of what PRP is doing. And really, any anti-inflammatories, even turmeric, the omega fatty acids, vitamin E. Personally, if you can avoid even icing it, I try to tell them not to do that. And then hydrations, it just helps with the blood draw. So Megan's my medical assistant, so I try to help her out by telling them to hydrate to make it a little easier. And then one of the things I've started is a lot of your platelets, they're up against your vasculature. So there's been some studies that show exercise for at least 15, 20 minutes beforehand can help demarginate it from the vasculature. And then one of those studies show that increases it by about 36%. So they come in a little sweaty, but if we can get a better outcome, I'm all for it. So this is here just showing you what anti-inflammatory can do to PRP. So the red, it's all different growth factors and cytokines, these four charts there. Red is before anything. Green is after they've been taking anti-inflammatory for 2 weeks. And then the blue is showing you once they've stopped it for a couple of weeks, they check it again. So you can see VEGF at the washout's higher, but the PDGF on the bottom left, you could see how much there is without anti-inflammatory. With the anti-inflammatory, the green, there's such a decrease in it, and then once it's washed out, it's kind of back to where it should be. But this is really just showing you the impact of anti-inflammatory. So I really have them stop it for at least a week before. As long as you do it at least 5 to 7 days before, that's enough half-life that it's eliminated out of your system. I did have a video about how that Arthrex single spin system works that we use, but when I clicked on it, it said I'm a bot and it didn't let me play it. So I just have this link up here if you guys wanted to jot it down, or you could just, if you Google Arthrex single spin system, it just shows you the process for getting the blood and how we spin it. So there's some clinics where they'll have you do post-procedural vital signs because they consider it a transfusion, but we don't do that here because it's autologous blood. It's your own blood. There's never been any transfusion reaction that's been documented. But so avoid anti-inflammatories. I personally say don't even ice it if you can. It's a natural anti-inflammatory. Try to avoid it. So after the injection, you want the PRP to kind of stay in that area. So I try to, for example, if it's in the elbow, try not to wear a sleeve, anything compression. You don't want to flush that PRP out. And then you get that pro-inflammatory response in the beginning that can last up to a week or so. Usually the first couple of days can be painful. I think Matt might go into a little bit more, but in terms of when to start PT. So after the PRP injection, for usually about 5 days to a week, we'll immobilize it. There's a great protocol that Matt and Bill McCafferty have out that we all really go by. And in the beginning, they're immobilized. They're not really doing much. And then after about 5 or so days, we'll stop the immobilization. They can start doing some gentle range of motion. And then after a week or two, we usually have them discontinued from their immobilization or their splint. And then with PT, you'll start with just gentle range of motion, stretching. So once they start that, and then you can start doing some techniques to kind of get rid of the diseased tissue as the PRP is doing its thing. So things like Graston, shockwave therapy can help. And then over time, once the new tissue starts forming, you can avoid things like Graston, but focus more on real rehab and start working on, you can start to slowly add eccentric exercises as well. So this is just showing us one of the ultrasound procedures. So you can see on ultrasound, bone reflects sound waves a lot better than other things like muscle tendon. So you see the outline of the patella very well. And then over the top of it, kind of that linear patterns, the patellar tendon, and then you kind of see the needle there. And you can see that arrow, it's pointing to the defect in the patellar tendon. So the goal in this case would be to kind of bring it in and put most of the medicine in here, and then also kind of fenestrate. So you can imagine if we're putting the medicine in the chair, then you're also fenestrating or passing that needle through this tendon. There's always a risk of rupture. And so for that reason, well, in the case of the patellar tendon, we'll usually immobilize them in a T-ROM locked-in extension to not really stress it. And even once they come out of it, there's still a risk of it. So that's why we have that protocol to try to avoid that. I did have another video which would show you the fenestration, but again, YouTube told me I'm a bot and I can't play it. So I just have these pictures up here. So this is for lateral epicondylitis. So on ultrasound, when we do it for tennis elbow, it's always a ski slope type appearance to the lateral epicondyle, which you can see here. And then that extensor wad runs all through here. Sometimes we'll put on color, and when you have tendinosis, you can see some areas of hyperemia, inflammation, like you see here. But we get that picture, and then if it's for PRP, I try to find an area of defect. So here's the same thing, it's just zoomed out a little bit. Here's that ski slope appearance to the lateral epicondyle, and then here's the needle coming in, and I usually put it in multiple areas, try to get it to the insertion origin site of the extensor wad, really all throughout. It can be painful because I'm not using anesthetic in here. I don't want to use anything that can impact the PRP. So what are the risks? I mentioned it before, it's already inside of you. So with that, it's very low risk. There's always a risk of infection if you're introducing anything external like a needle. There's always a risk of damage from the needle, like a complete rupture of your patellar tendon. And like I mentioned before, I don't take post-procedure vital signs. There's never been a documented transfusion reaction or allergic reaction. As with any injection, you can get localized pain and then vasovagal reaction. Usually in the big burly guys with multiple tattoos, you'll see that happen. And then contraindications, of course, if there's an infection, we wouldn't do it. If they have any type of blood dyscrasia, blood disorder, hemophilia, certain types of anemia can impact it. Of course, if there's an active malignancy, we don't want to draw those cells and inject it elsewhere. And then a relative contraindication for me is if they're on antiplatelet medicines, because if we're going to be doing a platelet-rich plasma injection and you are on antiplatelet agent for whether it's cardioprotection or stroke prophylaxis, it's going to kind of diminish the effect of our PRP. I will still do it as long as the patient's aware that the odds of it working are less because of it. Now, what are the barriers to PRP? It costs money. It doesn't work quick like a steroid injection would, or if you took an anti-inflammatory. And then here's the toughest part is if they're going to be getting this, like I mentioned before, we want them to stop anti-inflammatories, cortisone injections. So if they've been getting them, they're usually going to be hurting a lot in the time that they've stopped it. So really, for me, you want to try PRP before you've gone down the route of trying cortisone injections, because that can get a little tricky, but we'll still do it. So how can we collaborate? So best is to know how it works, how we do it here. So we use the ACP system from Arthrex. They don't pay me. I don't have any financial disclosures. The way our system works here is it's a single spin, and by that we usually get at least 3 to 5 times the concentration than would be in the blood that's just moving inside of you as of now. And then from a cost perspective, we're actually probably the most competitive I have ever seen. Where I did fellowship, it was 500, which was very competitive. People used to travel for that. And over here, 175, which is not bad. If you Google it, it usually says between 900 to 1,000. Now, there are some places that charge 3 to 4 grand for the same exact thing, so you have to be careful. Insurance does not cover it as of yet. I think there might be like an insurance or two that covers it for something, but I have a persistent, he's my patient, but to insurance, he's a customer, really. And he was very persistent with them. He gave them studies and they actually covered it. Now, I don't know if he got them to believe him or he was just persistent and it just worked out. So we talked about using an MRI beforehand, how it's helpful. And for most of the time that I do PRP, I'll use ultrasound unless it's into your knee joint because that's easy to just get into. There's a lot of good data that it works. So there's a lot of good data that it works for mild, moderate osteoarthritis. There's a lot of good data that it works for lateral epicondylitis, medial epicondylitis, Achilles tendinopathies. There's good studies. There's a lot of people that come to me and they have severe bone-on-bone arthritis. They've gone through this and that, and they absolutely do not want a new joint. This is similar to one of the patients I'm seeing. I talked to him that it does not work well in his case. I mean, you can see how his right hip looks. It looks great, but his left hip, I mean, this is end stage osteoarthritis. You've really lost that spherical shape of the femoral head. There's no space. There's a lot of sclerosis there. So this is pretty end stage. And I've told him about it. He still wants to do it. He comes every couple of months and he feels like it helps so much. So as long as they're aware, as long as the patient's educated about the risks, the benefits, and what the outcomes are, there's very low risks to it. So he's been doing well. So in terms of collaboration, it's good to know how it works. And then really, you kind of have to believe in it for it to work, right? And I mean, this goes, if I'm sending a patient to physical therapy and I send them by saying, go to physical therapy for 6 weeks and then I can get an MRI or else I can't, that's a disservice to the patient, to you, and to myself. That's a waste of time. If I'm going to send somebody to physical therapy, it's because I expect them to get great care and hopefully do well. If you're going to send somebody for a platelet-rich plasma, you have to believe in it, and the patient has to believe that it's going to work for them, or else it's not going to really work. So I'm going to show you not really studies that show that it works well, but studies that kind of go into how it doesn't really work well. But before that, this is just showing, it's a graph. So PRP has been around here maybe for longer than a lot of us have been even born, but over the past 10 or 20 years, there's been really, compared to here, there's an exponential increase in terms of articles and studies published on PubMed. And then, yeah, 2020 COVID happened, so the amount of studies went down, but I'm assuming it's going to start ticking up again. If you watch sports, you hear a lot about, there's been quite a few athletes this year that have gotten PRP injections. So this is just a study that shows that they talked about it for ankle osteoarthritis, and they said it didn't work compared to placebo injections. But just keep in mind, when you look at studies, I mean, back in the day, when I was a lot younger in high school, college, and a little bit afterwards, used to hear studies show that drinking lemon water does this for you. And I used to hold it so high and drank so much lemon water. I don't think it really did anything, but you got to really look at the study. So yeah, I mean, this study shows that it doesn't work for ankle osteoarthritis, but what else happened here? So in this case, they allowed anti-inflammatories up until the PRP injection. The Arthric system produces usually about 4 to 5 mLs. They only injected 2. And then they didn't really get into the PRP. How was it white blood cell rich? Was it white blood cell poor? Did the concentration? So you got to really look at the study. This is another study which I've had a lot of success using it for mid-portion Achilles tendinopathy, but in this case, they said it didn't work, and they didn't use ultrasound, which is standard of practice when targeting your Achilles tendon, especially if you're targeting a certain portion of it. Uh, and especially if you want to get it into that pathologic region, which I showed you pictures of. And in this case, they also used 5 mLs of lidocaine, 2%, which is double the concentration that we would use. And again, they didn't characterize the PRP. But with that said, you got to be careful. There's a lot of places that overpromise. They promise it as a cure-all. They'll do it every week so many times. For me, I'll usually try it once. If they get some benefit, they want to try it again in a couple of weeks, we can do it. If I do it one time, you get absolutely no relief. I don't think the second or third time is going to get you there. And if I do it once and you feel good, you're happy with how you're feeling, you're back to doing what you want to do, then I don't think we need to do another one. So in a lot of cases, it's often the good or best option, right? So it's safe, it's already inside of you. There's very few contraindications. It's one of those things that are natural. And the studies show that people who got steroid injection, yeah, initially they did better, but when they looked at them months down the line, the PRP group was doing a lot better in most of these instances. And then it's not a band-aid. It really tries to help enhance your body's healing to fix the problem rather than just put a band-aid over it. And even when you've tried other things, even if you've tried a steroid, sometimes it may work. But again, we try to go down one route, PRP, before trying other things, because then it can kind of negate the effects of it. Cons of it, it's out of pocket. It doesn't work right away. And there's a lot of things that it just doesn't have good data for yet. And then we talked about stopping medicines and needles. People don't love needles. Thank you. I don't know if you wanted to take questions now or after Matt is done.
Let's switch to Matt, and then we'll take questions at the end if that's okay.
Yeah.
All right. I'm getting on here, Steve. Let me know if you can see my slides in a second here.
Yes, we can.
Perfect. And you can see it. See my laser pointer too. All right, guys. So we're going to talk about the post-PRP rehab, kind of the rationale behind it, evidence or lack thereof in using it. And you'll kind of go through each of those phases here. If you are not familiar where to find it, you can go on our team's channel, OP Rehab, Unified Rehab Professionals, Protocols, and it's a post-PRP protocol. So really, overall goals initially, after PRP, we want to protect that injured tendon, prevent the rupture after tendinotomy or the fenestration if they're doing that. And then implementing a gradual increase in intensity, so that we're trying to stimulate, changes to that degradation of that scar tissue within the tendon, the hypertrophy and generate new collagen growth. So we really need to avoid vigorous, activities, especially early on. That's why they're being braced. It really depends on, I would say, each individual physician who's doing the injection. But we're talking, the first 1 to 3 days, they're being completely immobilized in most cases. But that again varies based on each case. This is a nice article. It just kind of shows the different tissue healings, post biological therapy. Most of the time, it's going to be for tendinopathies. So we have that 8 to 12 weeks of tissue healing, sometimes longer, depending how big of a defect there is or how big of an issue there was, or a partial tear or something like that. So we need longer healing times for that type of tissue. We need to start loading them with range of motion, isometrics, concentrics, getting into eccentric movements, and then into our plyometrics and return to play if they're an athlete. Just like any protocol, decision making should be based on criteria. How are they doing? Is it you want to tailor it to their specific needs too? What are their goals? Where do they want to be when they're done? Is it just for pain relief, or do they want to be able to do something better? That really has to come into our I'd say adjustment of this protocol. This is a systematic review. There's quite a few studies that included a we'll say, protocol for post-PRP rehab. There was some, consensus regarding the post-PRP protocols, although the rationale, is limited in terms of what they're implementing in said protocol. I found the same thing. We were designing our protocol. It was hard to find definitive support for each recommendation, whether it be EPAT, BFR. There was some small studies, case reviews, or expert opinion. I still feel like at this time it's probably the best practice. But I definitely think that there are better studies out there. We'll be doing updates when that time comes. So phase 1 of our protocol here, typically now, 4 days, 2 weeks, depending on when, they are limited. They're now going to be, still in the brace, but able to weight bear. Patients are only really doing range of motion exercises during this time. And I include this here, if any of you guys haven't heard of this before, the even up shoe leveler. More or less for your patients that are going to be in a boot for a long time, it can save you a lot of headaches in terms of, hip and back pain for those patients. Only cost $25 on Amazon too. The only bad thing I'll say is you might not have as many direct access evals for hip and back pain. So that's one bad thing. And then, we get into phase 2. This is our 2 to 6 weeks. Really, this is where we're going to see a lot of our patients coming into official outpatient rehab. The acute inflammation is resolving. They should be able to tolerate shockwave or instrument-assisted soft tissue well. The idea is that the shockwave will help improve the effectiveness of the PRP injection. And then we'll hopefully have better patient outcomes too. We want to continue and stimulate that healing and remodeling after the initial injection, and that inflammatory cascade, kind of keep that going a little bit longer if we can. And then we're using soreness rules to guide treatment and progression. That's kind of the idea behind the pain levels that you see all over the protocol here with the precautions. We don't want to do something that's getting them to the point where they're not going to be able to progress to the next phase or next set of exercises. A good way to implement blood flow restriction early on, if we're doing isometrics, is this quad set BFR on using NMES. I find that's a good way to really fatigue out the quad, get that quad firing. And it's also good exercise to reduce arthrogenic muscle inhibition too. That's something that, is a big issue, I'd say more so with ACL rehab, things like that. But, really hard to turn that quad back on. I haven't seen it as much with PRP, but it can still definitely happen. And then, another good example, if we're going on the eccentrics, sometimes it can be tricky, depending on what part of the body you're doing. Flex bar is a great way to load the wrist flexors, extensors eccentrically after a PRP injection as well. So, rationale for instrument-assisted soft tissue mobilization and shockwave post-PRP. We are trying to, like I said before, and Dr. Saleemi did as well, we're trying to remodel the portion of the tendon that was injected. We reverse some of those degenerative changes that are associated with that tendinopathy. Then when we enter into that remodeling phase, in that 6 to 8 week post-injection, the rationale to stop the shockwave is that we wanted to allow it to heal as well. So that's where we start kind of loading that tendon a little bit more. We might get away from BFR as well because they can actually tolerate, lifting some heavier weights and things like that. So, many of our offices have shockwave. Our version is called EPAT, which is a radial shockwave device. And the other version is focused shockwave that we don't have. And sometimes you might even need to use an anesthetic for that one as well, which is one of the reasons we do not have that. But both radial and focused shockwave have been shown to have positive effects on soft tissue and bone healing. So going forward, really, I'm just going to talk about shockwave for simplicity. Many of the studies out there will specify which one they used. A lot of systematic reviews will say that they both are effective. So for simplicity, we'll just call it shockwave. But this article describes 4 reaction phases of shockwave on tissue. All of them are things that help us heal. So post PRP, we're really looking for these things to happen too, right? We want some increased cellular activity. We want ability to nutrients to cross cell membranes easier. We want to have biological processes that help with modulating angiogenesis and improving bone and soft tissue healing. So all great things that we want to have happen. And then, this is a study that looked at shockwave and how it impacts the tenocytes essentially. So it promotes cellular proliferation and collagen synthesis in primary cultured human tenocytes. So it really just showed that collagen type 1 synthesis in tenocytes is increased compared to controls. Again, that's something that we definitely want to have happen as well when we're having someone with post PRP. Yeah, and if you want to learn more about the physiological effects of shockwave, this was a great article. It's about 25 pages long. It can show you more science than you ever wanted to know about shockwave. This was a slide from the article. It's a very complex model showing us the cell membrane, internals of the cell nucleus. Really, all we want to know is, and what it helps with is tissue regeneration and an activation of stem cell proliferation as well. So this slide, we're comparing PRP versus shockwave. So two separate treatments. That was a great study just to kind of see, if there was one that was superior to the other. Had a decent amount, 120 patients with plantar fasciitis, and they were randomized to either PRP or shockwave. Both had positive effects. I think it's a little blurry in the slide here, but I'm pretty sure that says 8 weeks, 16 weeks, 24. Blue is PRP, shockwave is red, and this is pain on this side here. Really, the only, I'd say, downfall of the study is that it just looked at pain. It should have some kind of functional measure, I would say. But the PRP group did superior to the shockwave group, but both had significant improvements, with treatment. Then this other study here, there were 74 subjects. Study design was a little bit better. They had 3 groups in which they had treatment of lateral epicondylitis, but PRP combined with exercise. They had shockwave and exercise alone. The PRP combined with exercise seemed to be superior to exercise alone or shockwave and exercise in terms of pain and function. They did have dash scores that were higher versus the shockwave and exercise or exercise alone group as well, which is not shown on here. And then this first study here, so this is now shockwave and PRP, the combination of the two, which is pretty cool to see as well. Not many large studies. I think this was the first study here was the largest one I could find. It was 33 athletes. Really just showed short-term effects, but the PRP and shockwave group at the 1 month mark, it was right here, PRP and shockwave, they had significantly lower pain levels for patellar tendinopathy. 3 months or longer, they were equal. But with them being athletes, and they didn't really discuss this in the study, is if they were able to return to sport faster, in which case that might be something that is beneficial for an in-season athlete as well. And the second one was a case study, which is pretty neat. I haven't seen this done, at St. Luke's, or I'm not sure if anybody does this, but it was a case study for a non-union proximal phalanx of the great toe. They had 3 months of conservative care. There was no healing, resulting in that non-union we described. And the treatment was a PRP injection to the fracture site, which you can very clearly see right here. And this is pre-PRP. The treatment consisted of shockwave and the PRP injection. And then after 4 weeks, this is B right here. You can see quite a bit of healing. Callus formation almost completely closed already. And then C was 8 weeks later. And this athlete was a track athlete, and I think it was a female. She was able to compete fully as a short distance track athlete. So really cool, fast healing case study in that case with PRP injection. And then this is a case report. So this was 2 patients, 69, 73. They both had shockwave with PT. They had improvements with functional outcome measures and pain. As they tried to return to a running program, they both had pain. They weren't able to fully return to running. Therefore, at that point, they were offered a PRP injection and several additional sessions of shockwave while continuing PT. Both were then able to complete a return to run program within the 11 weeks after getting that single PRP injection and continuing PT. So yeah, I think it was a good way to show that, we'll say traditional PT with shockwave didn't fully heal them, but the combination of the two had a big impact. And that's something I've had a few patients with similar outcomes, someone with lateral epicondylgia, that we got him like 78% of the way, and then like a month later he called back, saying that it was, pretty much about the same. Ended up getting a PRP injection, and then we did post PRP injection rehab, and he did extremely well. So I would say in general there needs to be some larger studies, but there does seem to be some evidence to support using a shockwave as part of our protocol, post PRP injection for sure. So moving on to blood flow restriction. I'd say it's another big part of our protocol post PRP. There's many studies on BFR safety profile and its use in postoperative cases. For those not familiar with BFR, we're looking for the biochemical cascade with low intensity training. We can't load them heavy right after a PRP injection. So we're essentially trying to trick the body to think it's performing heavy resistance training, which then leads to that metabolic stress, increasing growth hormone, and we get that inflammatory response, which increases neutrophils, macrophages of the area, all which can then help with that, skeletal muscle remodeling, if it's an tendon, it's also assisting with that as well. This is all ideal for our, phase 2 rehab. But does the evidence support it for PRP? That's the question. I could not find anything, other than clinical commentary about the combination of PRP and blood flow restriction, or comparing them against each other. Really, the best thing I could find, every which way I tried to search it, was this study, which is pretty interesting. It kind of goes along with what Dr. Saleemi said about the exercise prior to the blood draw. But it showed that doing one exercise, it was just BFR knee extensions prior to collection of the blood draw, essentially could increase the platelet and leukocyte count. They're about to start the study. I shouldn't say didn't show anything yet, but it'd be an interesting study for us to maybe do as well. And then really, so a lot of what we're talking about in our setting is the tendinopathies. So kind of looking at BFR and tendinopathies, I think is a good way to kind of look at the impact of BFR, since that's what they essentially have. There are some good studies on that. This one found, low resistance training with blood flow restriction simply had better results than a sham procedure for BFR. So I think that's helpful in that regard. And then blood flow restriction for tendinopathy. This is a case report of in-season athletes. Both athletes had experienced improvements with BFR-based therapeutic exercise program. They were able to compete throughout the track season while doing BFR, which is ideal if someone's in season. We want them to still be able to train. They couldn't tolerate their traditional training in this case, which is why they were receiving this care. So really what it did, you can kind of see in the imaging here. So this is pre-BFR. You can see the hypoechoic areas in this diagnostic ultrasound right here. And then this is post. You can see some thickening here as well. So, decrease the thickness of the tendon. Then post, you don't see those areas anymore in this image as well. And they were able to improve tolerance to their sport as well throughout the treatment, which is also ideal during in-season training. So then we get into phase 3. We're getting away from BFR and shockwave. We're still trying to gradually load the injured area. This is still criteria based at this point. Tenderness should be pretty low. Pain with IDLs, walking, stairs should all be minimal to non-existent as we progress in this phase. We really shouldn't start a return to run program until they've met that criteria. And then, the St. Luke's Running Center does have a return to run program and testing readiness to run. I would say, that would be something that'd be great for everyone to look at if you're not too familiar with getting, patients to return to run. And then, of course, we have the St. Luke's guidelines for return to play for upper extremity and lower extremity. If this athlete is, returning to a organized sport, they should also be able to go through and pass that assessment as well prior to release from the physician. And then, since we're on to return to play, I was curious if there's any articles out there about, returning to sport faster with PRP. So I found a few studies. Again, smaller size. Not always the best study design with some of these, specific topics, we'll say. But the first study here, athletes with grade 2 muscle strain were randomized in 2 groups: PRP and exercise versus exercise alone. The PRP and exercise group returned to sport on average 3.9 days sooner. but there was no difference in re-injury rates at 2-year follow-up. So, you know, 3.4 days can be pretty significant, I would say, in return to sport time frames, especially depending on the sport you're playing. And then the second one was with NFL players. The cohort study comparing players who did and did not have received PRP. Injections were compared. They received PRP within 24 to 48 hours after injury. There was 108 players in total. The days missed were not considered significant based on their power analysis, but the PRP group did miss one less game, which with a large financial impact of returning to play one game sooner, the authors said PRP injections for treatment of grade 2 hamstring injuries may be advantageous in professional athletes, which are great. Yeah, one game sooner is much better. And that concludes the post PRP protocol. Thank you all for listening in. Any questions, anybody?
Feel free to unmute your microphone or type into the chat. While we're waiting for, go ahead.
If you guys ever have any questions, feel free to reach out either through my email or through Epic Secure Chat. I'm usually checking them at all times. Even if it's something small, you have a question about if somebody needs PRP, if we can do this, I'm always there to collaborate, and whether it's PRP or really anything else.
That's great. Thank you.
Yeah, thank you very much. So you alluded to it a little bit. Actually, both of you alluded to it a little bit earlier. What in your experience thus far? What tends to be the biggest hangups or issues that you see when you get a patient for the first time that that they should know ahead of time that might make them more appropriate to refer. So whether it's coming to PT after a PRP injection or a PT referring to for a PRP injection, what kinds of things should we be telling them to effectively counteract any of the media issues that they would read online?
So with a lot of these injuries or chronic tendinopathies, acute injuries, they should really all be starting with you guys. A good PT program time, usually that's enough. If you give it time, their progress is stalling, you want to do something to maybe speed things up, you can send them over to get things moving faster. I mean, usually when I see them, whether it's a referral from one of the orthopedic surgeons or another group, the first time they come see one of us in primary care sports, it's a consultation, because there's a lot to get into, right? So there's some contraindications, which we often have. There's some medications they might be taking that they now either can't get it, or if they do get it, it's not going to have as much of an effect. And then but that insurance doesn't cover it, so we got to go over pricing and how it works and what they expect, because it's pretty involved when they come in. I mean, they get their blood drawn, they're getting the injection, they're going into a brace, so there's a lot happening. So if there's anything, always feel free to send them. I mean, the first visit is going to be a consult, but if you can catch them, if they haven't had any type of steroid injections, if they haven't gone down that route, and they're willing to do the work, because I'm sure you guys have seen it, passive treatments tend to be wanted more than active. But this is one of those things where if you're not also putting in the work afterwards through your PT or home exercises, it just doesn't work.
Yeah, that's what I was gonna say. The last part you said, just the fact that you do have to rehab it afterwards. It's not just a injection like a steroid injection. And the other feedback I've gotten from patients is just it hurt more than they thought it was going to happen or going to hurt. So I think that's something that we can tell them it's not, if they've had other injections, it's not the same procedure as that, just to give them the heads up. And I think I'm sure they get described what it is right before the injection, but it probably still more uncomfortable than they thought. And the cost, I think most patients have been excited about that because I think they Google the cost and they see what you're talking about, where it's $900 to 1,000, and they get told it's would you say 175? They're pretty excited about that. So I think it's reasonable.
Yeah, the pain part is the big thing because it's one of those things where they're coming in to see me or one of the other guys and they're actually leaving feeling worse, right?
Yeah.
Because if it's like a tendon issues, we're just putting the PRP in it, we're fenestrating, we're causing injury, and then it's usually painful enough that even if you want to kind of immobilize so they're at least a little bit uncomfortable, and then after you do that, you're telling them, yeah, you can't take any of these medicines that would help you. You just have to deal with it. So it's tough. They really have to be motivated and into it.
Thank you very much. Somebody put it into the chat, and I'm going to elaborate a little bit because they were asking about upper extremity with shoulder injuries versus patellar. A lot of the studies that you highlighted were about lower extremity, and one of the studies that was presented was about epicondylalgia. Are there any specific differences in outcomes that you know of between shoulder injuries and knee injuries with the use of PRP?
So if I go back and look at the past few years, what I've done it most for would be partial rotator cuff tears. So those rotator cuff tears that they're not really amenable to surgery, but they're also pretty impactful in that it's hard for them to do anything and it can take a while. Because it's kind of that gray area where surgeries, they usually don't go for it. So, and I've had a lot of success with it, especially for those uh, bursal surface tears, closer, more superficial than articular. But I've done it for both, and you know what? A lot of people have done very well with that. So that's just my anecdotes. I don't really have any studies I can point you to for that, but just from my experience, I would say majority of the partial rotator cuff tears that I get, they do very well. And then, of course, there's a lot of studies on the epicondylopathies like lateral medial that they do well with. In terms of I've done it for labral tears in the shoulder. That's been a mixed bag for me. And I mean, otherwise, yeah, those are the big things that we do it for in the upper extremity. Uh, TFCC injuries, those are very tricky. Most surgeons don't like to go in for that. I don't have any studies. I haven't really done it for that, but it's something I'd be willing to try in the right patient. But to answer your question, anecdotally, partial rotator cuff tears I've done very well with it.
Thank you. You mentioned about partial rotator cuff tear. Is there any amount of acuity or chronicity that works best? Like if somebody had a partial tear, 5 years ago, do you see that do better or worse than somebody who's, 6 weeks out?
If you can get to it early, I think it's better. But yeah, I mean, even if it's chronic, they have those chronic changes along with it, like tendinosis, and they still have a partial tear there. I've done it for them, and one of the things it does well with is the chronic issues like tendinosis. So, and the good thing with that is that we can pick it up on ultrasound. You can just see the change in the tendon structure because of the chronic changes, and then just getting it right to where you need it. So even if it's chronic, if their progress is stalling, I've done it for them, and like I said, most of them have done well. If it's a really high grade full thickness, barely hanging on, I would have them talk with the surgeon first, because when we do it, where I'm going to be fenestrating, so me fenestrating through something that's almost completely torn, odds are I'm going to make it I could make it a complete tear that ends up needing surgery anyway. So even for the small partial rotator cuff tears, I'll tell them, or any of the tendon partial tears, or even if it's not tendon, there's always that risk of rupture. But I think it's higher when it's a bigger tear. So I usually have them talk with the surgeon first.
Excellent. And Dr. Johnson, have you seen any differences in rehab afterwards for rotator cuff versus knee versus epicondylata versus whatever?
So so I have not had anybody with rotator cuff tear, post PRP yet. But in comparing, say, elbow versus patella tendon, or Achilles. I've seen all those now. Achilles, the one I saw, it would have been a great case study to share with everybody, but the imaging modality was different pre and post PRP, but it did show healing of the Achilles tendon. It was a partial tear, and he had a PRP injection. So that would have been a neat one to share. But he was immobilized a lot longer. So I'd say that was one big difference. Because of the partial tear, they're probably concerned of completing that tear if he wasn't immobilized as long as he was. But in comparing, say elbow versus patella tendon, I'd say they both did well when it was more for tendinopathy. They kind of went along the same timeline as well.
Excellent. As Dr. Saleemi alluded to earlier, please make sure that if you have any further questions, reach out to either him or Dr. Johnson. And thank you very much for attending, and thank you for your questions.